My original training is in neurology as an MD, and then subspecialty training was in behavioral neurology, and originally worked just in behavioral neurology, but got interested in epilepsy because of it's a unique window on the brain and on behavior and cognition. And in that context, among other things that we were looking at, was looking at drug effects on cognition. And they had done this in adults, but worried that it might be a bigger effect in younger patients. And in particular, I found animal studies that showed that you could give animals in utero, expose them during the mother's pregnancy to a drug that at a dose less than produced malformations, congenital malformations, but the baby animals when they grew up had cognitive impairments. So I worried that this happened in humans, and about just around 2000, a little bit before 2000, we began a big study with the NIH, a multi-center study called the NEED study, Neurodevelopmental Effects in Anti-Epileptic Drugs. This study is still going on. It's now retitled MONEED, which is Maternal Outcomes in Neurodevelopmental Effects of Anti-Epileptic Drugs. And it's looking at both the baby and mother's outcome. The results of our prior decade of research have shown that one drug in particular has bad effects on the baby's cognitive thinking ability, and that's a drug called valproate or valproic acid. And this drug has a 7 to 10 IQ point drop in the children exposed to this neuro compared to the other major seizure medications. So it poses a particular risk for cognitive outcomes. It also poses a risk for higher risk of congenital malformations compared to other drugs. Our ongoing study is looking at new drugs, drug combinations, and what happens to the child, but also what's happened to the mother in terms of seizure frequencies. We know that some women have changes in seizure frequency during pregnancy. We don't understand why. Part of that may be due to changes in drug metabolism. For some drugs, it can be very marked. It can be drug clearance can increase 200%, which means the level will drop in half, and then the mother might be at increased risk for seizures. We're looking at those factors. We're looking at OB complications like C-sections. Women with epilepsy have increased risk for C-sections, but we don't know why. So we want to understand why they're having more C-sections. Mm-hmm. And finally, our pilot data has shown that women with epilepsy have increased risks, a marked increased risk for depression in the postpartum. So people with epilepsy, man or woman, have increased risk for depression. Postpartum is an increased risk time for depression. And you combine the two and you get very high risk factors. So we're studying that and looking at what factors contribute to that depression. We have 20 centers in the United States, spread out across the United States, that are presently enrolling 350 women with epilepsy. We're still enrolling. We are not completely enrolled. We're also enrolling healthy pregnant women without epilepsy who act as controls for the babies and for the OB outcomes. And we also are enrolling women with epilepsy that are not pregnant that act as controls for the effect of the pregnancy on the seizures and depression. This, you can find more about this on clinicaltrials.gov, and we're actively seeking women to come into the study. Our enrollment is on target, but we're still enrolling. From my perspective, the main reason a woman who is pregnant, whether with epilepsy or not, want to be in the study is because of the extensive testing that's given to the child and early referral for any problems that we might find, like language delay or autism problems. It's the drug exposure to the child that we worry about, both in terms of malformations or in cognitive or behavioral outcomes. Some drugs look pretty safe, like lamotrigine and levetiracetam are pretty safe-looking drugs, and then some drugs look much worse, like the valproate drug or phenobarbital that we're talking about in this regard. There's a great deal more to be learned. There are big registries, like in North America, it's the North American Pregnancy Registry. It's looking at the congenital malformations, and women can join that registry by calling the North American AED Pregnancy Registry. The number is, you can find it online, and they have to call themselves to join it. But it's a no-risk kind of study that allows collecting information has garnished a lot of information for us. There's other registries in other parts of the world. The largest one is the EURAP that's out of Europe. It covers several different, about 80 countries across the world. So while we've learned a great deal in the last 15 years, we still have a great deal more to learn, and there are a lot of seizure medications that we don't understand the risk, and we don't really understand the combinations very well. So that's one of the things we're looking at here. We're still learning more about the drugs themselves and learning about the drug combinations. Most women with epilepsy go through pregnancy on a single drug, but there's a reasonable subset of anywhere from 20 to 33% of women that are on polytherapy on more than one drug, and we don't know how those combinations may increase risk. Some of the old data from the old drugs suggested they might increase risk when you're on more than one drug, but it still is a question that's not been delineated, and in particular we don't understand if combinations of new drugs may be safer than the combinations of the old drugs. The combinations are really all over the place. Maybe one of the more favorable ones is the lamotrigine levetiracetam combination, because those two drugs independently as monotherapy look pretty safe in pregnancy. And but the other combinations, it's a real mishmash of different types of combinations, because the reason it is there's no good evidence base to figure out which combination to use. So in the absence of adequate evidence, then the care kind of disperses out in different directions. Over the short term, our major focus is on enrolling in this study and maintaining retention and getting to our major outcome variables, which once we get the enrollment, about 9 months later, we'll get the pregnancy, OB complications, seizure frequency, pharmacokinetic change kind of data. Another 9 months after that, we'll have the postpartum depression data, but it'll be another 6 years after that before we get all the full data on the kids, although we can collect pretty good data at around 2 years of age that is predictive of what's going to happen to the kids later in life. Just by 6, we can test it a lot more detailed.